Okay, we'll get started. Thanks for everybody's attendance. Welcome to our June 50 Vets in 50 States event. This evening, we're lucky to have Dr. Ellis, and it's sponsored by ViewRay. We're going to talk a lot about radiation oncology this evening and some of the new technology that's been out. A couple of updates for VPCa. We've participated in I think almost all of the major oncology events, AUA and ASCO, and now SNMMI, the Society of Nuclear Medicine Molecular Imaging. Our roundtable series has kicked off. We've got 2 under our belt now, and those videos are being posted on our website. So we encourage everybody to visit those. If you've got questions about doing or having care, or any questions about the VA, we can certainly get you in to talk to the right doctors and the right stuff. And you can see what some of the discussions about issues related to veterans care for prostate cancer are. Coming up, and we've got a break, I think, in the summertime for the next month or so. And then we've got some more events coming up. We'll be at Astro. We'll have another roundtable at Astro focused on radiation oncology and how vets can access it, as well as both inside the VA at the 41 sites and outside the VA where they don't have care. So we'll be talking to a lot of the leaders in radiation oncology during that roundtable as well. So that's great. I think we're all ready to go. And Dr. Ellis, I'll turn it over to you for a quick introduction, and then and let you get into your presentation.
Great. Thank you very much. I appreciate you guys taking the time to come and hear this tonight. And I appreciate that you're able to record this. So if anyone wants to catch this in the future, they're welcome to reach out to us here at Genesis Care in Fort Myers, Florida. Just a little background about myself before I start things here. I'm born and bred in Buckeye in Columbus, Ohio, trained at Ohio State, but then transferred to Case Western Reserve and took my first job as a GU radiation oncologist in 1996 and helped lead their center for many years, becoming vice chair and director for GU oncology, but vice chair of radiation oncology at University Hospitals of Cleveland at Case Western Reserve, before I took the inaugural chair position at Penn State University, where I actually had the pleasure of installing my first ViewRay system for MRIdian. And then I got recruited down by a friend of mine that was the chairman at Emory University, a gentleman by the name of Wally Curran. Wally was contacted by a company called Genesis Care and asked if he'd consider leaving academics and joining them as their global chief medical officer. For those of you that aren't familiar with Genesis Care, this was the first company to install MR-Linacs in the world. They put 2 in Australia, 3 in England. They're installing 2 now in Spain, and our first installation was here in the United States at Fort Myers. So I'm very proud to be recruited here as their medical director for MR-Linac in the United States a year ago, and to talk a little bit tonight about my experience using MRIdian to treat men with prostate cancer. So I'm going to take a few minutes here and share my screen and take you through about 35 to 40 slides. If there's any questions, you're welcome to interrupt me. I'll try not to stammer too much as we go through these, and hopefully you'll find this entertaining. And again, feel free to ask any questions. And I think this is the screen that I want to get to. And I'm going to share. Is that coming across okay for everyone?
We're great. Loud and clear, Dr. Ellis.
Great. Well, again, I appreciate the 50 Vets in 50 States for inviting me to speak here tonight on the MRIdian Smart for radiation therapy for prostate cancer. Again, my name is Rodney J. Ellis. I'm a radiation oncologist by trade. I'm a co-chairman for the NCI Renal Task Force, a member of the NRG GU steering committee that makes all the national trials for prostate cancer in the United States for radiation, and serve, as I said, as the medical director for MR-Linac technology for Genesis Care, located here in Fort Myers, Florida. So welcome, and thank you for inviting me tonight, and thank you all for your service. Okay. When we want to look at navigating prostate cancer treatment and options, we know that 1 in 8 men will be diagnosed with prostate cancer in the United States. Some patients don't need treatment. We can do watchful waiting or active surveillance. If they're low grade and may not warrant treatment, it may not yet be life-threatening. And certainly, typically, any treatment we do is going to have side effects. So sometimes we can delay treatment and try and catch it before it becomes life-threatening, but before it's spread to any other sites. There's generally two ways we look at treatment, either a short course of treatment or a long course of treatment. Under the short course, typically surgery would be one example where you come in as an outpatient, typically nowadays, have the prostate removed, typically robotically, and stay in the hospital for no more than 2 to 3 nights before you're discharged home. It takes a couple of weeks to get the catheter out afterwards, but most patients by a year out say, I don't have incontinence, my sexual function may or may not be the same, but hopefully it's preserved, and the cure rates can still be very good, on the average at least 70% for surgery up front. Now that does mean that some patients fail, but they can go on to get radiation as a cure for attempted surgery that wasn't successful on the first bite. The other two short course treatments include brachytherapy, which I'm very well known for. Doing brachytherapy means we're putting radiation sources into the prostate, either permanently or temporarily. Permanent seed implants are an outpatient procedure where you might place up to 100 seeds into the prostate, leave them there as they lose their energy over time and never bother removing them. They're safe to leave in place. The patients get their seeds, leave the hospital as an outpatient, and get their daily radiotherapy over 8 or 9 weeks as they're walking around doing their day-to-day business. There's also high-dose rate brachytherapy, where you typically do at least 2 implants and use a single source that goes in and out of the needles that are placed to give the radiation. And often that may be combined with external beam radiation as well. Lastly, and more commonly being performed nowadays in a short course, is stereotactic body radiation therapy. Many people are familiar with CyberKnife, which is one of the first technologies that came out and did this. And CyberKnife still works very well and is currently treating a lot of men, probably the most men, with stereotactic radiosurgery. The difference and the advantage of CyberKnife, the difference compared to what we're going to talk about tonight, is it only images occasionally during the treatment. Every 5th time it moves to a new position, it takes an X-ray to see where the prostate is, and then adjust and make sure the treatment's being delivered as planned. That does require an invasive procedure to put needles into the prostate to place gold seeds so that it can be seen on an X-ray. But it's otherwise a very effective form of therapy for prostate cancer. And again, is the most common way that men are treated right now with stereotactic radiosurgery with 5 fractions of radiation. The more common treatments we see are what we would refer to as long courses of radiation, typically in most men nowadays for 7 to 9 weeks. And that may be either proton therapy or external beam radiation with IMRT. I won't go into any of those a lot greater in the detail today, but if you have any questions about that, I'd be happy to do so. I ran the proton therapy program that we had at Case Western when we were the first in the state of Ohio to start proton therapy, so I do have a lot of experience with it, but I greatly prefer the 5-fraction treatment to a longer course of therapy for most men. Some quick statistics. There's a lot of men diagnosed every year with prostate cancer, nearly 300,000. There's someone diagnosed about every 2 minutes. 1 in 8 men will be diagnosed with prostate cancer in his lifetime, and it's the 2nd leading cause of death for men in the United States. There's about 35,000 men that die annually from prostate cancer. Fortunately, there's over 3.1 million survivors in the United States. Again, typically in radiation oncology, we'll look at weekly treatments, Monday through Friday. And in most centers in the United States, we're still talking about 9 weeks of treatment for 45 or 44 treatments. Now, that's despite the fact that there's now 5 clinical trials that say if you give a larger dose every day, you could reduce the number of treatments anywhere from 20 to 28 treatments over 4 to 5.5 weeks. But again, most men in the United States, if they go see a radiation oncologist in a community site, are going to be told, yep, we can treat you. You're going to come Monday through Friday for 5 weeks for 44, 45 treatments to complete your therapy. The other course is the SBRT, or short course therapy, but it's typically only offered to about 10% of patients currently in the United States that are newly diagnosed with prostate cancer. And I hope to change that, and I'll show you some of the data that's being developed to make that change happen. At MRIdian centers, over 85% of the patients that are treated with a short course for 5 fractions or less. That's compared to conventional treatment centers where less than 10% of their patients that come in with prostate cancer are offered SBRT as a definitive treatment. It does require not only the right machine to do stereotactic radiosurgery, but more importantly, the right team to safely deliver these very large doses of radiation with precision and accuracy. And that's why it's not yet the most common treatment that we'd see. Now let's bring up a kind of scarier topic, the fact that prostate cancer has a high recurrence rate. They say 20 to 50% of men that are treated for prostate cancer may suffer a recurrence, whether they're treated with surgery or treated with radiation up front. The number of patients that are newly diagnosed with high-grade cancer is actually on the rise. Back in 2004, it was less than 12% of patients. By 2016, it's up to 20.4% of patients, and has been shown to be rising because of the change in screening for prostate cancer. There became fears that we were over-screening and over-treating prostate cancer, which I agree we were. Nowadays, we often use active surveillance to not treat until patients become higher grade. But the probability of recurrence at your time of treatment is often driven by how high your risks are. And by risk, I mean risk for disease beyond the prostate. For low-risk patients, at 5 years, the risk of recurrence is less than 33%. For the average patient, it can be as high as 50%, and for high-risk patients, can be up to 85%. So it helps to screen and look for prostate cancer and treat it before it becomes high grade. The good news is, in patients who recur, MRIdian SBRT may be an option for salvage treatment. If patients fail surgery and fail salvage radiation and have recurrent disease within the prostate or elsewhere in their body, stereotactic radiosurgery with MRIdian is certainly an option, using PSMA PET imaging to treat them. Even if patients have had full dose of prior external beam radiation and suffer recurrence within the prostate, I routinely treat patients right now using MRIdian, offering 5 fractions of radiation to just the part of the prostate that shows changes based on their MRI and their PSMA PET scan. So I just wanted to bring that up. So when patients hear about a high risk of recurrence, they know that there may be a way to salvage that may not require further surgery. When we talk about MRIdian SMART, and SMART stands for Stereotactic MR-Guided Adaptive Radiotherapy, we often use the terms see, shape, and strike to talk about the benefits of using MRIdian. The MRIdian uses a high-value MRI, on-table adaptive replanning, and real-time 3D tissue tracking to have automated beam control. You can see these images over here, but I want to take a couple of minutes to dig into this a little bit deeper. First, there's diagnostic quality MR imaging. That's new to me. As a radiation oncologist, this image on the left is what I was typically working with for many years. This is a cone beam CT. I can see the backbone, I can see the ribs, I can see some shades of gray and white and black, but it's hard to see the organs clearly, as opposed to an MRI where I can delineate and draw and say, there's a liver, there's a kidney, there's a stomach. I can see the anatomy. And we've never been able to do that in radiation oncology during treatment before. This allows us to strike or shape the radiation. I think I missed a slide. Let's see if it'll give it back to, sorry. My forward button's only working when I click there. So yeah, there's our C. We're getting optimal imaging and targeting of radiation therapy using this advanced technology. The next thing we're going to talk about is the precision and the personalized medicine that allows us to shape the radiation. In this case, we're talking to a patient with pancreatic cancer on initial plan who's got a stomach in purple that's just outside of the field of radiation. When he or she came in for their next treatment, the stomach had moved and was closer to the field and much larger, invading into the area that the original plan intended to treat with radiation. But only on MRIdian can you adapt and change the plan while the patient's in the magnet, and then deliver a safe plan daily up to all 5 times that you're treating the patient to shape, in addition to seeing the tumor as you're treating the patient. Now, next, I want to make a point on conventional treatment margins. We normally, because we can't see as clearly, add a larger margin. so that if anything's moving during the treatment, it's still keeping the tumor within the treatment field. But to do that, we've got to treat more healthy tissues surrounding the target. Usually we'll use a 7 to 10 millimeter expansion, say around the lymph nodes in prostate cancer, and even a 7 to 10 millimeter expansion around the prostate if we're doing 9 weeks of treatment. If we're doing 5 treatments with SBRT on a standard linear accelerator, we'll still use typically a 5 millimeter margin, maybe 3 millimeters posteriorly, and that's the current standard of care in the United States. However, with a MRIdian, you can come down to a 3 millimeter margin in every direction because you can see the prostate much more clearly, and you do not need to use fiducial markers or an invasive procedure to treat the patient daily during his treatment course. That's how we can strike the tumor when it's in the right position, as you'll see in this video. As the machine is treating, let me see if there we go. Let me see if the video is going to work. Here we go. Here in this video, you can see the treatment beam coming on, and you'll see the machine changing to the next angle for treatment. And in this panel that's going to expand, you'll be able to see the bladder. You can see the prostate in blue. You can see the target margin in red, but you can see the machine turns itself on and off. If anything makes the prostate move, the machine turns off. As the prostate comes back into position, the machine will strike and treat only when it's in the right position. And that's uniquely available only on the MRIdian. The MRI controls the beam. This is not a human process turning it on and off. We're imaging 8 times per second and only treats when it's in the right position. Here in this patient with an abdominal tumor, you're treating the pancreas, but it's only going to treat when it's in the proper position. We're going to strike and hit the tumor, and you see the signal that the beam is coming on and off in yellow only when it's in the right position. The patient can take a deep breath and hold it, and we give biometric feedback so they can actually watch this. You'll see this in the video at the end, how they can help us to deliver their treatment in a timely fashion by not letting the anatomy move. Now, in prostate cancer, that's not as critical because we're further away from the diaphragm. But as you saw in the previous video, a gas bubble or changes in the prostate's bladder filling connection can alter the position of the prostate and change the treatment. And again, only with MRIdian are we able to see that, use these tight margins, and only treat when the prostate's in the proper position, and use small margins to avoid treatment to the rectum and the bladder. But what clinical evidence do we have that MRIdian's better than other treatments? I'm going to walk you through some studies today. This is the hard part if you're not a scientist. I'll try and keep this interesting and not dry. But first, I want to show you a timeline. ViewRay, the company that makes the MRIdian, was founded in 2004 and got clearance in 2012 to treat with their first patients using a cobalt source. The first trick was, how do you make an MRI that will run with something that delivers radiation? And the first approach was to use cobalt radiation sources, because they always are making radiation. You just have to open up the shutter and let the light shine. By 2016, though, they'd improved the technology and figured out how to put a linear accelerator and an MRI in the same device and not interfere with each other while they treat. So they got clearance in 2017, and Washington University was the first site that had one of these units, first the cobalt, now the more modern unit, and have treated over 1,000 patients. Similarly, Amsterdam University, Seoul National University, and UCLA have all treated over 1,000 patients. And GenesisCare this year will reach our 1,000 patient mark as well. Currently, treatments for MRIdian are typically using in 22% metastatic lesions. Say, for example, someone that has a lung cancer that spread and has resisted their chemotherapy. There's now data saying if you go after these metastatic lesions, if there's a limited number, as they call oligometastatic, you can give tumor-directed therapy and make patients live longer with their disease, despite the fact that they might be progressing on their chemotherapy. So we're seeing a lot of referrals for this technology on MRIdian. Likewise, pancreas cancers, I showed you in the previous video, because the pancreas moves, doing 5 fractions of radiation with pancreas cancer again, can be safely done on the MRIdian, but is very difficult to do with other machines. Likewise, cancer that is spread to the liver or started in the liver, or cancers that are in the lung that are moving with breathing, especially if they're located in the middle of the chest, are all great candidates for treatment on the MRIdian. But tonight, what we're focusing on is prostate cancer. That's currently about 21% of the patients that are treated on MRIdian. And in my center, because I am a GU radiation oncologist, I'm hoping that I can get up to 90% of my patients to be GU-related treatments. So I'm more than happy to see any patients that are interested in the MRIdian if they've got bladder cancer, prostate cancer, kidney cancer, anything in my wheelhouse. This slide shows my slide that represents the trial that I serve as the principal investigator for. As I said, I'm a co-chairman for the NCI Renal Task Force, but a member of the NRG GI Steering Committee. In 2014, I came up with the idea of opening this trial, comparing standard radiation for either 20 or 28 treatments rather than 9 weeks to 5 treatments using a linear accelerator. This was the first clinical trial that was ever written to allow for the use of a MRIdian MR-Linac. We opened the trial in January of 2017 and accrued all 633 patients in June of 22. We did actually get 1 patient treated on this trial using a MRIdian before the trial closed. But now we're starting to see more centers open up and are available to treat using this technology and following the guidelines of the trial that I wrote. We treated patients in 6 countries: the United States, Canada, Ireland, Sweden, Hong Kong, and India. This trial was written to show that the 5 fraction would be better, not only for reducing bladder side effects, but also to be better by 30% for disease survival. What that means is that if either one of these endpoints are proven to be true, then because this is a phase 3 trial sponsored by the NCI, this will go into the NCCN guideline as the preferred way to treat men with prostate cancer as the standard of care using 5 fractions. So hopefully over the next 10 years, as this data matures and publishes, this will drive most men to be treated in 5 fractions rather than 9 weeks. But what trials do we see that are currently available based on MRIdian? I'm going to start with a conventional trial called the PACE-B phase 3 trial. This is very similar to the GU-005 trial I just spoke to, but it was based on CyberKnife, and it was comparing CyberKnife to linear accelerator doing 78 gray of radiation versus 5 fractions with the CyberKnife. So 5 weeks versus 9 weeks of radiation. They accrued patients to this trial more successfully on this PACE-B than their initial trial, PACE-A. PACE-A was hoping to compare surgery to radiosurgery, but it's always been difficult to get men to let you flip a coin and say, I'm either going to remove your prostate or irradiate your prostate. So that trial failed to recruit adequately, but PACE-B successfully completed its accrual and reported its late toxicity, showing that the GU or bladder-related toxicity and the GI or rectal-related toxicity were essentially equivalent, whether you did 5 fractions of radiation or 9 weeks of radiation. That set the pace for the MRIdian trials to start being presented. And we're going to touch base on 5 trials just very briefly today, but they're all going to give you a key take-home message that using smaller margins helps to reduce toxicity, causing fewer side effects, does not require fiducial markers for an invasive procedure because they're being treated on an MR-Linac with the MRIdian. The first trial we're going to report on is a phase 2 study that was reported from Amsterdam University. They treated 101 men, and these men had various risk factors, most for medium or high risk, very few low risk men, because in Europe, they generally will do active surveillance for low risk. But once these men crossed over to the point of needing treatment, they offered them 5 fractions of radiation with the MRIdian, with or without the addition of hormonal therapy. They recently reported their acute findings on this, but they showed that their grade 2 toxicity within the first 90 days occurred in less than 25% of patients, and only 5% had any significant GI toxicity. Now, again, compared to the previous slide where we talked about PACE-B, they were reporting late toxicity, and showed there was very little toxicity with SBRT after 90 days. This trial, because it's so new, has only been able to report within the first 90 days. And I suspect we'll see another paper come from this group on their late toxicity, and they'll probably be one of the first groups that gets to publish data on outcomes, because they were one of the very first to start treating patients. The second trial I'd like to focus on just came out in January of this year. This was the MIRAGE trial done by my friend Amar Kashan from UCLA as the principal investigator. This was a phase 3 trial, so they were randomizing between two different treatment options, and that reported its data with 154 patients. It was initially scheduled to have 300 patients, but after 1 year, as part of the structure of the trial, they did an interim analysis to see how much side effects the patients were having. This trial was written to show that the MR-guided SBRT was superior than the regular cone beam-guided CT treatment planning for SBRT. When they did that interim analysis, they saw the results were so markedly different that the patients being treated on the new technology were getting so much fewer side effects, they actually had to close the trial because there was no longer equipoise. You couldn't flip a coin and put the patient on the machine that you now knew was the worst machine. So patients after this trial were published, if they're available, would all be treated on the MRIdian. This showed that within early 90-day, they were looking at the primary endpoint for grade 2 toxicity, and early 90-day grade 2 GI toxicity, biochemical control, overall survival, and quality of life. What did they find? They saw a 60% reduction in the odds of GU toxicity and no GI toxicity. 10.5% in conventional treatment, 0% on the MRIdian. Dr. Kashan, when asked how he accomplished this, said it's potentially explained by the magnitude of the margins that can be used with the MRIdian. By tightening down to a 3 millimeter margin, we're treating smaller volumes of the normal tissue. None of these patients actually required adaptive daily treatment. They were treated with simple treatment. They had the treatment plan done, and they used that plan for all 5 treatments and accomplished these outstanding results. And that's available, again, only on the MRIdian. So Dr. Kashan went on to say, well, what about in the postoperative setting? If someone has their prostate removed, as I said earlier in the talk, there's a 70% cure rate, but 30% may have a positive margin or a rise in PSA afterwards and get radiation. And we know that we can typically cure half those men to end up with an 85% overall cure rate. 70% with surgery, half the failures get cured, adds 15%, you end up with an 85% cure rate. In this trial, he wanted to compare using cone beam CT to image-guided radiotherapy and showed that he was able to get a 35% reduction in the acute GI toxicity to the bladder and a 32% reduction in the GI or rectal toxicity up to 6 months. Here's just another summary slide saying that that was a 32% reduction, but showing the MRIdian treating these patients with a very small margin where the prostate used to set and excluding as much of the bladder as you possibly can. With standard treatment on a non-MRIdian where you can't see the field as well, you would make this field much larger and treat all of this section of the bladder in the field. Using this technology, they're testing whether we can use image guidance and the smart technology to treat a smaller field and treat this as well in only 5 fractions to a slightly lower dose than we use for intact prostate, since this is typically microscopic disease. The next trial I'm going to look at shifts course from the West Coast to the East Coast. This is done by Dr. Nagar, who's the principal investigator at Cornell University in Lower Manhattan. This is a joint study opened both by UCLA and Wales University and is being opened at Genesis Care in our center in England as well. They're recruiting 136 patients, and this is a current active trial. They're asking the question, if we can treat in 5 fractions to 37.5 gray and have such great results, can we possibly do it in 2 fractions of only 25 gray, matching what is done with high dose rate brachytherapy as commonly employed in Canada to give only 2 treatments to patients, but in this case, doing it non-invasively with no needles, no markers, no invasion. The primary endpoint will be genitoury and urinary symptoms for the 5 versus 2 fractions, and we're awaiting the closure of this study and the data to be reported once enough time has passed and we've accrued all the patients to the study. He went on to do another trial looking at bladder cancer, similar to the Scimitar trial that we presented earlier. Only now, this is a phase 2 randomized trial where they're taking 134 patients, men or women, that have had bladder cancer and are treating to see whether or not they can get a shorter, oh wait, I apologize. This is a post-prostatectomy. I'll get the bladder cancer. This is post-prostatectomy, that they're looking at 20 fractions at 55 gray. So instead of the traditional course, it's 38 fractions at most sites in the United States. They're doing 55 gray and 20 fractions versus only 5 fractions. Again, using the same small field that was used in the previous trial, and then calling this shorter for its acronym. Again, this is recruiting now. We'll have to wait further data to see if it's going to become a standard of care, but it's very exciting to see this technology being explored with this new mode of treatment with the MRIdian. So what are the MRIdian 5 and what does this matter for prostate cancer? The points I'm trying to show from this data is that we're able to give ablative doses to only treat the tumor and no need to limit dose because of movement into nearby organs at risk, or OARs, such as the bladder or the rectum. We're able to accomplish this using tighter margins to use lower side effects, as reported in the MIRAGE phase 3 trial, attributed to the real-time tracking and automated beam control on MRIdian. We no longer require fiducial markers to be an invasive procedure before patients can receive their treatment. We can complete the treatment in 5, possibly fewer fractions, and we're seeing no grade 2 or grade 3 toxicity in the MIRAGE trial for either bladder or rectal toxicity. What's really exciting for me, and what I want to show the group here today, is how does this machine work? The 3 screens that you're looking at today are identical to the 3 screens on the new MRIdian that we just installed for Genesis Care here in Fort Myers, and is the upgrade from the previous machine that I installed at Penn State University. Here we're seeing a large screen that the radiation therapists are looking at, while we've got 2 separate screens we're using in the same room, or for that matter in any other room, that the physicist and the radiation oncologist can all see. We're going to put on a video first showing here in the pink is the original image, in the gray is the daily image, and the therapist are lining the patient back up and making sure they're in the right position on the treatment table before they direct their therapy. So once they get it lined up, they'll turn it over to the physicist and the radiation oncologist to do what they call segmentation or contouring of the organs at risk, the prostate, the bladder, the rectum, making any corrections for gas bubbles or liquid versus solid tissues that are in the surrounding image of the day, and doing a new treatment plan if necessary prior to delivering the treatment. And we can work in this in parallel, which means while one person's working on one part of the screen, another person could be working on a different screen on different parts of the plan. So as opposed to the previous version, where it may take 2 hours to deliver the patient's treatment daily, we're now routinely treating patients, even with complex replanning, in 45 to 60 minutes. So that allows us to treat more patients each day and keeps patients from having to lay on the table for more than an hour for treatment. And I think that's a real breakthrough in the new MRIdian technology that I'm very, very happy we were one of the first sites to have in Florida. There are now 5 MRIdians in Florida, and there's 100 MRIdians in the United States, over 200 MRIdians globally in the world. And we go on to the next slide, because that one gets a little boring. Here we go. Now, as we're looking at the planning session, I wanted you to see what it is we're doing in the background while a patient is laying on the table, waiting to get his treatment delivered. So this shows the contouring of the rectum, the electron density evaluation by physics to correct for changes in the materials. And you can see how quickly we're all working at the same time, doing different parts of the treatment. Right now, the therapist is doing the alignment. Everyone else is waiting for that. Once the alignment's complete, we're going to shift gears and have the doctor and the physicist start doing their part. And then we turn it back over to the therapist to finish treating the patient and their daily treatment. Again, in prostate cancers, we're doing this day to day in about 15 minutes. In pancreatic cancer, we're doing it day to day in about 60 minutes. But for me, this is a really remarkable change in what I'm used to in my workflow, and just brings us so far into the state of the art that I think it's going to be years before anything else catches up to it. So earlier before the talk, we were talking about CyberKnife versus MRIdian, and this is really showing that kind of a difference. As I said, CyberKnife uses invasive markers to see where the prostate's at with X-ray. It looks every 5th treatment to stop and make sure it hasn't moved and adjust for any motion, where with MRIdian, we're doing this 8 times per second, stopping if anything moves, only delivering when it's on target, definitely an advance for the treatments. Let me see if I can take you to the next slide. If you're a patient and you're laying in the MRIdian, we now have a pair of glasses we can put on you that have a mirror to let you see backwards. So this would be the view you would see as a patient. And you're seeing at the top of the machine, and you're able to see your own anatomy, or we can turn the anatomy off to just let you see the structures that we're seeing. Some people don't like to see their anatomy, some do, but we're giving them biometric feedback. We're looking in 3 different planes at the same time. So you can look at sagittal, coronal, and axial slices through the patient and see things moving. You can see if the tumor's in the right place. When it's in the right place, you see these smiley faces that shows the patient saying, hey, you're doing a good job. Keep it right there. It's only when it's right there that the beam comes on. When they take a breath and it moves off, the machine turns off, but it gives them this feedback so they can help complete their treatment in a very timely fashion. And again, only will treat the tumor, will never treat the surrounding tissue to give any risk of damage to the surrounding normal tissues. Lastly, I want to show this slide here that shows it's a little sped up, but this is a treatment for a patient with prostate cancer. Not in real time, we're going to go a little faster, but what you're going to see in this as I start the video is we can turn on and see the dose being developed in the prostate during the plan. And if you, for example, have an interruption in the plan midway through, such as I had a patient yesterday, he was the first patient we treated that had an MR-compatible pacemaker, but we were the first place in the United States in a community setting to be able to turn off his pacemaker, place him in the unit, treat him for his cancer. And unfortunately for him, we had to interrupt his treatment during the end of the last treatment. This was for a pancreatic cancer, not a prostate. But this machine's able to record where you're at and then pick back up for the next fraction. So you're going to see that in a minute. This again is in a prostate cancer, but you're going to see how the dose, once we get started, here's the angles the machine's coming from. When you see the yellow, it's treating. It moves to the next level. Once it gets that, you're starting to see beam building up doses of radiation on the prostate as it's rotating around, giving it from the different angles. By the time we're finished, it's going to be at this last angle and have a full dose of radiation to the entire prostate, precisely sparing the rectum and the bladder. I'll let this run through for just a few more seconds so you see that effect. And I think we're doing pretty good on time, so I'll let this video finish. And then we've just got a few more slides. And then I can open it up for questions for anyone that's in the audience or anyone that may have joined late. And it looks like we just 3 more angles to go. It's telling us it's got 2 more minutes to go to complete the treatment. This is running in fast time, so it's going to finish in just a second. And there you can see the red dose of radiation covering the entire prostate with a high dose, the prescribed dose just to the edge of the prostate, and very, very rapid fall off of low doses of radiation coming in from the other angles. So I thought that was pretty cool to show. So where can veterans go to get MRIdian treatment? Well, fortunately, the VA that I used to work at, the Lewis Stokes VA in Cleveland, Ohio, now has a MRIdian and is treating patients on the North Coast. So patients in that location can certainly be treated within the VA system right now in Cleveland, Ohio. The good news is that the VA has also purchased 3 additional MRIdians already to be placed in Ann Arbor, Michigan, Houston, Texas, and Oklahoma. But those are not yet treating. For vets that are interested in the West Coast and MRIdian, again, we showed the data from UCLA. That's certainly a center that's VA approved for patients to go. And you'll find that there are other centers in other locations and other communities around the United States as well. If they're on the East Coast, the Weill Cornell Medical Center in Lower Manhattan certainly has a national reputation. And as I say, hospitals that are offering MRIdian treatment can be found at the MRIdian locator page on their website. And you can contact the hospitals to confirm that they're part of the community cancer network that will approve your care at that hospital. An example for us is the Genesis Care USA in Southwest Florida's Gulf Coast. Again, my name is Dr. Rodney Ellis. Here's our phone number and our address for the center. And for patients that are interested in coming to see us, we are located in Fort Myers, Florida. This is our webpage. This is the regional cancer center that houses our MRIdian. We are very conveniently close to the airport that's just south, just 15 minutes from this site at the GSW is the term for the airport there, but the Florida Fort Myers Airport. And just north of us in Punta Gorda, about 15, 20 minutes north of us, is a smaller airport that Allegiance Air controls. But if there's cheap flights, you can get them in and out from Allegiance Air. We also have made arrangements with hotels nearby our center, the Holiday Inn Suites, the Candlewood Suites, and the Hyatt Hotel that are negotiating terms and prices for us for veterans or non-veterans that want to come and be treated. And I believe that there is a veteran reimbursement program already set up through the VA for veterans that want to travel somewhere other than their local community if they don't have access to a MRIdian in their hometown. I think that's all I had as far as the slides that I hadn't hidden. I wanted to see if anyone in the room had any questions or any slides they wanted to go back and look at. But I would again like to thank all of you for your service and thank you for inviting me for your time and allowing me to come in virtually to speak with you tonight about the MRIdian. Thank you very much.
Yeah, thank you. Thank you, Dr. Ellis. I mean, it's a great presentation and obviously great technology that is becoming available more and more. I had a couple of questions for you. One, are you seeing or is anyone using any of the like the gel implants, the space or that sort of that, or is the would they use that in a tough case or not at all? Or you think you got the margins down close enough that you don't need the space or type stuff?
Sure. So for anyone that's read any of the articles on space, or you'll see that I'm a co-author on 6 of the papers that were published on that original trial. We were one of the lead academic centers that did that of the 19 centers. And I was actually the first physician that was privileged to use space OAR off trial. Once our trial closed, I had a patient I was doing a low dose rate brachytherapy implant that I was offering to place that after his implant because he had rheumatoid arthritis and I wanted to reduce the dose to the rectal wall. So I've used a lot of space OAR. It's very easy to place and very beneficial to use. The question is whether it's necessary to use in stereotactic radiosurgery. In the GU005 trial that we talked about, we allowed use of either a rectal balloon to keep the prostate from moving to prevent the tight margin from becoming a problem, or a space OAR, or both, or nothing. We didn't mandate you do it one way or the other, but we allowed all 96 centers to use it however they wanted to use it. As it turns out, about half the patients did get it. So we will have some data coming out shortly on whether there was toxicity and a reduction in toxicity for stereotactic radiosurgery, the way there was proven reduction in toxicity with 9 weeks of radiation. There's also a trial that's open called the SABRE trial that is funded right now by Boston Scientific, as they've developed a new space OAR device called the Space OAR View because it has contrast in it. And in order to get that available outside the United States, they need to get some safety data. So we do have the SABRE trial open as well for patients who want to do 5-fraction SBRT. On that trial, 2/3 get it, 1/3 don't, just like the original trial that got it approved. I'm happy to use it on any patients, happy to offer that trial. We do treat patients off clinical trials with space OAR if they desire it. So I do have urologists that partner with me to place that. And I'm anxiously awaiting data saying, do we necessarily need to use it in all patients? There are certainly some patients I feel very strongly we should use it in. I saw a patient today that had recurrent prostate cancer. His PSMA shows disease within the prostate. He was treated nearly 20 years ago outside of Florida. And I'm going to plan to see if we can place a space OAR in him, if it'll go in, so that when I give the additional 5 fractions to the part of his prostate that now has recurrent cancer, I can reduce the dose to the rectum. I also use it, though, in patients that are newly diagnosed. If they're concerned about the rectal toxicity, we offer that routinely for patients, to answer your question.
No, that's great. So Dr. Ellis, on the question of, I guess I think it used to be true, and then maybe they did some studies on oligometastatic disease. If it is, outside the prostate now, are you able to use MRIdian on multiple sites at the same time, or at the same treatment?
You can, if it's within the treatment field. Now, again, because the MRIdian will turn on and off depending on motion, you may, if you're only doing 5 treatments, want to treat one site and then another site. But we do specialize in tumor-directed therapy for disease outside of the prostate as well as within the prostate at the time of a recurrence. If patients have disease only in the prostate, we'll treat just the area of the prostate they've got recurrence. If they cured their cancer in the prostate but failed in a lymph node, we can use MRIdian or other techniques to give stereotactic radiosurgery to lymph nodes that are involved, or bony metastases that are involved, or solid tissue metastases for that matter, if we needed to. So yes, I do believe there is a role for treating patients that have recurred using stereotactic radiosurgery with or without a MRIdian.
And what about, treatments for like small molecular, that some of the unseen cells, or they might think they're unseen, that would be floating around in a recurrent setting in your pelvic? Are there ways, or are you using MRIdian to do like full pelvic radiation at a lower level, lower doses, or are you just using it for SBRT?
The MRIdian can be used to treat high-risk patients, and if you want to treat the pelvic lymph nodes, you could still do the pelvic lymph nodes in 5 fractions while treating the prostate with 5 fractions. Some of the more exciting trials that are currently open within the NRG, including GU009 and GU010, are both looking at high-risk men and using Decipher to see whether they have a benefit for more aggressive hormonal therapy or less aggressive hormonal therapy, for example, 2 years versus 1 year, or adding an oral agent with the LHRH. And on that trial, since it's not a primary endpoint for radiation, they will allow any form of radiation, essentially, including use of MRIdian, to treat 5 fractions, to treat the lymph nodes and the prostate at the same time. Now, there are many patients I see that are newly diagnosed who nowadays are able to get a PSMA PET scan as part of their initial screening if they're high risk. And we're seeing that we're finding metastatic disease in lymph nodes more often than we thought we were going to see those. I often use a wider field of radiation with or without the MRIdian to dose paint and give, say, 2.5 gray to the prostate while giving 1.8 gray to the lymph nodes that look normal. And then any lymph node that has disease in it, escalating the dose to tolerance. By that, I mean giving as high as 2.5 gray per day to the PET positive disease, as long as it does not exceed dose to the surrounding normal tissues, such as the small bowel, rectum, or colon. I've even been treating patients now that have disease in the back of the abdomen up to as high as the kidneys, and offering them what I hope is going to be a curative treatment, even though we see some disease outside of the pelvis.
Okay. Open the floor up. I'm hogging the questions. Anybody?
Yeah, Dr. Ellis, this is a great presentation, and it's so good to see how far technology has come.
Isn't it?
I was treated in 2012 with brachytherapy and external beam MRIRT, and because of the technology not being what it was today, it cost me my bladder.
Wow.
So it's so good to see how far it has come. The work that I do now with advocacy work, and also with helping newly diagnosed men decide, navigate their course of treatment, to be able to talk to them about how things have changed and how much better the treatment is to limit the the side effects and quality of life issues that I had to suffer is huge. So I want to thank you for the presentation and for what's going on now in the field of radiation treatment and technology.
Well, let me first say I'm very sorry to hear about the side effects you suffered as a result of the combination of treatment. We do have data that shows that the combination of treatment is more toxic than brachytherapy by itself. And we do believe that there's potential benefit to getting higher doses of radiation in the prostate itself with brachytherapy. But yes, it's very hard to train people how to do brachytherapy properly. I've spent many years of my career just teaching residents how to do brachytherapy, but brachytherapy is becoming a lost art. There's not as many people that are gifted and well-trained in doing it. And there's some cases where you are going to have harm to patients, even if you do it all correctly. And so I think the stereotactic radiosurgery is a way that we can non-invasively offer brachytherapy-like doses, like the trial that they were talking about, the 5 fraction versus 2 fraction that we talked about in the talk tonight. That's essentially mimicking what we're doing with high dose rate brachytherapy to get it down to 2 fractions. And I do believe that we will see data in the future that says maybe it's not about escalating the dose of radiation, it's about de-escalating the dose of radiation to respect the normal tissue tolerances, to avoid doses to the bladder and the rectum, and use advanced imaging such as the PSMA PET to give dose escalation to the dominant lesions of the prostate. I even published a trial that we did in Cleveland where we only did 3 fractions of radiation and only treated the part of the prostate that had biopsy proven and image positive disease and did not treat the rest of the normal tissue. Now that's experimental. We did it in a limited number of patients. We saw good outcomes, but that needs to be reproduced before it's ready for prime time. But I think that's a vision into the future. Only in prostate cancer do we still treat the whole organ. When you have head and neck cancer, I don't treat your entire head and neck to the same dose. When you have lung cancer, I don't treat your entire lung to the same dose. Only in prostate cancer do we give the radiation to the entire organ because previously we had no way of imaging and knowing where the disease was at. I'm not saying that our imaging is perfect nowadays, but nowadays we often can see where the biggest chunk of the tumor is. And so I routinely dose escalate the region in the gland that has high-risk disease that's biopsy proven and give standard or lower doses to the surrounding tissues that may be at risk of damage from the radiation.
That's great, Doc. The one thing to, as a reminder to everybody, if you're talking to vets, make sure that I know that Kayla and the team at VPCa have done a good job of making sure that all the sites are in the community care network or under contract. So this qualifies under one of the conditions that the VA, or if your VA doesn't have this technology, you can request to get, to have this treatment or have this type of treatment with the technology. So yeah, as you talk to guys newly diagnosed or even recurrence, like Dr. Ellis said, I mean, these guys can treat you now on a recurrent setting as well.
Yeah, and as I say, we are authorized with the VA to treat veterans. My goal in putting the second unit in is to really make it a GU focused unit. We're treating pancreas, we're treating lung cancer, but I enjoy helping not only veterans, but all men that have prostate cancer because of our family history. That is really the site I spent my entire academic career trying to improve. And I'm happy to see any patient who's interested in learning more about whether they think this technology may be helpful to their diagnosis. So again, I appreciate you guys letting me keep that up on the screen and encourage anyone to contact us that would like to see us for a consult and consider a mini vacation down to Fort Myers to get your cancer treatment and go to the beach.
There we go.
Yeah, hello, I'm here, Mr. Harry DePauler.
Hi, Harry.
Hi, how's it going, guys? I'm from the DMV. I'm starting a prostate cancer group down at the VA hospital here in DC. And I'm obviously an advocate for prostate cancer as well. And I noticed, great presentation, by the way. I did everything everybody else did prior to me. However, I'm just curious. I was treated with prostate cancer in 2013, or diagnosed. I was treated in 2014. I did a 14 year of watchful waiting. but I watched it, and I didn't obviously do as many biopsies as I probably should have. But when I did catch it, 14 years down the road, it turns out that I had out of 12 snippets, if you will, I had a biopsy, and 9 were positive, and some as high as 85%, one high as 95% out of the 12. So
What was your Gleason score?
my Gleason score initially, it was started out at 3+3,
Sure.
but it turns out that I went back. I'm the one that took it a step further. I took it from the VA and took it down to George Washington Hospital, or Georgetown. I'm sorry, Georgetown Hospital.
Yep.
They gave it to me in a small container, and I put it in. They put it on ice, and they took my biopsy. I took my biopsy down there. It was about a 30-minute trip. Took it down there, and they sent it to their pathologist, and it turned out to be, as opposed to 3+3, it turned out to be 4+3, which is closer to 8, which is a little worse than 3.
A little bit higher grade, yeah, but still very treatable.
Yes, absolutely. And I decided, excuse me, I decided on brachytherapy and seed implants. I had 87 seed implants, and I spent 8 weeks, 8 weeks of radiation. And anyway, where I'm going with this is, I've talked to a number of people, and it turns out in 2014 there were very few people that were following their patients. And I'm talking, most of the guys worked out of hospitals. Most of these radiology oncologists worked out of hospitals, and they determined, and I'm trying to figure out, most of the people that I talked to had no idea about following their patients. In other words, they couldn't give you a cure rate. I noticed that you mentioned a cure rate. I'm just curious to find out how you would obtain your cure rate. And I'll go back I went through, I was my doctor's 15,000 patient. I don't know if you're familiar with Radiotherapy of Georgia.
I am very familiar with Ham Williams and his group, yes.
Mr. Christ,
Yep.
Dr. Christ. Okay,
Yep.
well, he treated me, and I was his 15,000 patient. He was the only person out of 6 people that I dragged my wife to for various types of therapies that could give me a cure rate. All these guys, none of them could give me a cure rate. And I determined that, based on the fact that these guys can't give you cure rates, is because they don't follow their patients. So
I can address that for you, Harry. You bring up some very good points. And Ham Williams started that cross-decision technique at RCOG years ago, back before CT scans were available. He'd put the seeds in and then give external beam afterwards. And I can tell you that on my cure rates for intermediate risk patients like yourself, I've got a cure rate that matches or exceeds any other published data. And yes, I'm one of the few people that have 10-year data recording my own data on what my cure rates are. So I think you're right. It is spot on to say, when you go to see a doctor for their treatment, they can quote what other people's treatment are, but what's their cure rate? And not everyone is academic and follows their data. I spent my entire life in academics dedicated to GU oncology. So I understand where you're coming from.
Okay,
but I do think nowadays, with the technology we have, we can often treat either with just 5 fractions of radiation alone, or external beam radiation, either followed by seed implants. Potentially, I think we might have a day where we'll get this approved to do a wider field of radiation to the lymph nodes and 5 fractions of the prostate, or again, in an ideal world, 5 fractions to the lymph nodes and the prostate at the same time. But more studies have to be completed. I encourage patients that are interested to be part of a clinical trial, if they're eligible, to enroll in these clinical trials, so that we can move the needle and find out where the line in the sand is to get the highest cure rates. But Harry, it sounds like you had very successful treatment, but it was a very aggressive treatment that you had done.
I did. I was very happy with it. And he gave me an 85% cure rate. And he said, had I come to him possibly a year or 2 earlier, he could have possibly offered me a 95% cure rate.
My cure rate at 10 years when I was doing brachytherapy was quoted to be 89% for intermediate risk and 96% for high risk, and 78% for high risk, 96% for the low risk patients. But again, I've got away from doing brachytherapy now that SBRT has become available, because it's less invasive. You don't have to put the markers in, you don't have to put
Mhm.
needles in, and you're getting brachytherapy-like doses. And again, allowing patients to complete it in 5 treatments and get back to their family, get back to work, get back to their life, not spend 9 or 10 weeks moving somewhere and staying with someone to get their treatment done for a month or 2. At the most, someone may have to come and stay with me for a week or 2, or find a center, hopefully, that opens closer to them so they don't have to travel. And that's my goal in life by the time I retire, is to prove that SBRT should be and will be the most dominant form of treatment for prostate cancer and should be available locally within every community.
I stayed on, you mentioned you had gone to Emory University. I stayed on that campus while I was being treated as well.
Yeah, my partner that hired me, he was the chair and the director. He was the chair of radiation oncology at Emory and the director of their cancer center, Wally Curran. And so he is now currently the global chief medical officer for Genesis Care in the world.
Wow. Very interesting. Well, thank you, doctor. Very
That's
good.
good stuff.
Very good.
Thank you.
Doc Ellis,
Yeah.
it's Keith. I just got a quick question.
Sure.
Is there any discriminating factor to consider for a veteran if he has the options of MRIdian or CyberKnife? And CyberKnife is also SBRT, correct?
CyberKnife is SBRT as well. Whether we do CyberKnife or a linear accelerator, when you look at the study, the Mirage trial that I quoted, that was using standard linear accelerators. Standard linear accelerators were not capable of doing SBRT when CyberKnife was first invented, but they are today. And whether it's a conventional linear accelerator or CyberKnife, I really consider them essentially equivalent. The CyberKnife is a little bit better in that if there's motion during the treatment, it corrects for it. But the CyberKnife takes 45 to 50 minutes to deliver the treatment. On a standard linear accelerator, once you line up to the gold markers and start your treatment, you're done in less than 5 minutes. So there's not likely to be much motion during the treatment, but you still have to put a larger margin around the prostate in case there is any motion. The MRIdian, because it allows 3 millimeter margin, or some places are saying we can take it down to 2 millimeter, like the Mirage trial. Some places are saying, why even add a millimeter? It's right on it, treat it. It only treats when it's in the right position and you're checking it 8 times per second. I don't think there's any machine on the face of the planet, nor will there be in the next 5 years, that'll be able to say they can do that most likely.
So basically, if I'm understanding it correctly, it's precision versus time.
Yeah,
No,
the cure rate's going to be the same. Whether
Same.
you do a CyberKnife, a linear accelerator, or an MR-Linac, your cure rate's going to likely be the same.
What
The
about-
difference is going to be your side effects and whether you have any late treatment related side effects.
Perfect. Thank you, sir.
You're welcome. Thank you all for the time tonight.
All right, one more time around the horn. Anybody last minute questions?
I've got a very quick collateral on the hydrogel. You said there's a new version of it out?
There's 2 companies that make hydrogel. Barrigel is a new company that came out with a barrier. And then the initial company that markets one is now Boston Scientific. That's a Space OAR. And the
Right.
Space OAR came out with a new type called Space OAR View. It's got some iodine encapsulated and attached molecularly to the gel. So it can't leach out into the normal tissue. It doesn't affect people that have iodine allergies, but it lets you see it on a standard cone beam CT or CT scan. I don't need the new gel for my MRIdian because the MRIdian will show the gel as a white deposit on an MRI. But if you're being treated on a linear accelerator as a standard treatment, then the gel is very helpful because it puts the distance between the prostate and the rectum, makes up for the fact that you can't come down to the tight margins that I can give on a MRIdian, and helps to make sure that the therapists are lining up to the right spot to treat it. So I like that new gel quite well for patients that are interested in it. My question is, do we need the gel or not if we're treating with an MRI? And I don't know the answer to that now.
Yeah, the reason I asked is, and Mike knows that I do support groups with ANCAN, so I get a lot of those kinds of questions, in our sessions as well. Thank you.
No, you're welcome. And again, I think that's the difference between my site and many other sites. You've got to have a radiation oncologist that's dedicated to GU oncology and prostate cancer, and the team and the machine surrounding me. It takes a village from the person at my front door to the person on my back door to run patients through the system and get them the best outcome. I've got to have the right team and the right equipment. And we're very proud to say in Fort Myers, I think we've got one of the best sites in the world.
That's awesome. It's great to know. You will probably see some more stuff from us, Doctor. But yeah, I really appreciate your time tonight. I mean, I think the briefing was spot on. It's great information, and we'll make sure that we distribute it out to our network. While we know that ViewRay is still rolling out, they're not across the entire planet, but I hear there's a great upside in and more facilities are buying the MRIdian machine and getting them put in there, and the training's increasing. So it's all great. We will help put out the word and make sure the guys know where they're at and that they're great options.
Great. I'll just put one last plug, because it's going to be the clinical trials and the data from those trials that drives everyone to know what the best machines are and where the places are to go. So any patients that are interested in coming to a center that has a clinical trial that's offered to them, if they're interested in being candidates, I encourage them to consider doing so, because that's what we rely on, is the subjects that are kind enough to volunteer to the trials. And we're forever grateful for their faith and patience in us to help improve the quality of life, not only for them, but for all the patients that will follow them.
Oh, that's great. Well said. Well said.
Thank you.
Anything else? Anything from Steve? You have anything to add, Kayla?
Just a huge thank you, Dr. Ellis. This was incredibly educational. I really like how you took us through, basically just sort of the options and then the benefits of SBRT across multiple modalities, and then the sort of the details about MRIdian Smart. Thank you very much for your time and all the passion you have for treating cancer patients down there in Florida.
Great. Thank you, Steve. I appreciate it. Thank you all again for your service.
Thank you.
Excellent presentation. Thanks.
Hey, gentlemen, you have a great evening.
guys.
Thank you so much for giving me your time.
Yeah, thank you very much. And reminder, it'll be on, this will be posted on the website along with the presentation and available for view. We'll most likely have it up tomorrow or Thursday. So look for it on the website. And again, thanks again. Everybody have a nice night.
Thank
Thank
you.
you kindly,
Thank you,
Keith.
you too.
I look forward to meeting you in person. Thank you.